Thank you very much for inviting me to speak at the conference on clinical management of our aging HIV patients. So these are my disclosures. As we are seeing an aging population of people living with HIV, clinical management of our patients becomes far more than just suppressing the virus to undetectable levels. Rather, the issue of healthy aging is becoming paramount in the care of our patients. We are witnessing the proportion of older adults rising markedly in the last 2 decades. And as our patients age, many of them suffer from one or more age-related chronic diseases. We also observed that our patients suffered from premature aging. Various cohorts have shown that they had higher prevalence of age-associated comorbidities, and importantly, these comorbidities occurred 5 to 10 years earlier than in the HIV uninfected population. Not surprisingly, people with HIV also have higher prevalence of various geriatric syndromes like multimorbidity, polypharmacy, cognitive impairment, frailty, and functional disability. And this burden of geriatric conditions was translated to poorer quality of life, as well as greater burden to the healthcare system. Recognizing the potential burden and impact of these geriatric conditions in older people with HIV naturally leaves HIV physicians asking whether one should include more comprehensive assessment of these geriatric conditions in our routine care. A comprehensive geriatric or aging assessment often includes various domains, like assessment of mobility and physical function, mental health like depression and anxiety, cognition, frailty, functional status, which usually includes activities of daily living and instrumental ADL, as well as quality of life, which reflects a person's general state of well-being. But what does all this mean for HIV clinicians? Will performing these assessments benefit our patients? Will these assessments lead to changes in our clinical management? And if yes, who are the patients who would benefit most from these assessments? And what exactly should be done, and by whom? And how should this form of geriatrics care be delivered in our clinics? Few would disagree that our ultimate goal in providing healthcare in HIV medicine is to improve quality of life for our individual patients. The first step in achieving this is obviously to assess their quality of life. However, many clinicians would wonder, how does assessing quality of life impact patient care? In fact, one of the goals of measuring health-related quality of life is to use the results as a stimulus for behavioral change for all those involved in healthcare. For the clinicians providing direct patient care, quality of life assessment would allow a rethinking of values to be taken into account in decision-making by raising our awareness of the multi-dimensions of health-related quality of life. It also allows identification of factors that can serve as targets for improving quality of life, which include physical health, mental health, and their associated social determinants. Similarly, performing a more comprehensive assessment of the geriatric conditions for selected patients would allow us to better understand individual patient needs. It would allow identification of problems that are not detected during regular clinical visits. For example, uncovering functional deficits and other health and social concerns. Importantly, since many of these functional deficits are reversible, identifying these issues would allow timely interventions with the ultimate goal of improving quality of life of our patients. The collection of these data through assessment of these geriatric conditions would also guide improvements in our healthcare system by identifying issues, for example, the stigma or social needs of our aging patients. Although incorporating aging issues in HIV clinics would benefit our patients, questions still remain for the who, what, and the how. Currently, there are some existing models of managing problems related to aging at HIV clinics. Some centers have developed geriatric HIV programs, which involve geriatricians and multidisciplinary teams. They often have some specific referral criteria and include some forms of geriatric assessment. These programs do have the advantages of providing holistic care by aging specialists, but at the same time need adaptation from usual geriatric services, as older people living with HIV are generally younger than the usual geriatrics patients. Another model is the modification of existing metabolic clinical programs, which originally take care of more complex comorbidities, but now included some specific geriatrics issues. The clinic that I'm working at in Hong Kong belongs to such an example. The advantage is the relative ease of incorporating age-related issues into an existing infrastructure serving older people with HIV. However, there is a risk of focusing too much on multimorbidity at the expense of the psychosocial needs of our patients. There are other models that involve digital health with a focus on patient engagement in healthy aging. For those of us who are seriously contemplating starting geriatric HIV programs at our clinics, there are some existing models that we can take reference to. Most of these clinics see older individuals, often defined by the age of 50. These patients are either self-referred to these programs or referred by their HIV or primary care providers. These programs involve multidisciplinary teams, including both HIV and geriatric specialists, as well as other healthcare providers. While some programs have more focus on age-related comorbidities, mainly the physical health, others involve a more multidimensional geriatrics assessment, which may involve discussion with patients with regards to age-related concerns or even goals in their life. The interventions involved in these programs usually involve making recommendations for ART adjustment and arranging screening and diagnostic tests as appropriate. They also involve referrals to specialists for further management and also psychosocial and behavioral recommendations. These programs are generally very welcome by the patients, and some did show improvement in quality of life as well as mental and physical function. Most of these programs involve co-management with their primary or HIV providers. And successful programs may involve partnering with community-based organizations to provide psychosocial support. The co-location of geriatrics and HIV service is obviously a convenience for patients. At the same time, some problems may be identified. One example is the increase in awareness of stigmatization of aging from the patient's perspective. As mentioned, the clinic in Hong Kong that I am currently working at initially look after patients referred for mainly metabolic and other comorbidities. However, as our patients are aging, we have incorporated screening of several geriatric conditions. The information shown here is some preliminary data on the first 150 patients undergoing such assessments. The average age was around 62, and most had long-standing HIV infection. Comorbidities were fairly common, as shown in the diagram here. We observed common issues of multimorbidities and polypharmacy. But more of a surprise to me, in this cohort with an average age of around 60, 20% actually had fall in the past 12 months, and 30% experienced symptoms of urinary incontinence. A quarter of them showed poor performance in physical performance testing in the clinic, and around 10% had one or more impairment in the instrumental ADL, and the majority of them had evidence of pre-frailty. We also identified many of these geriatric conditions being determinants of both physical and mental components of quality of life. When we first started to include these geriatrics assessments in our clinic, we were fortunate to obtain advice and assistance from our collaborators in our center, including geriatricians, clinical psychologists, and neurologists. Our research team received training from them on the various assessments we provided to our patients in our clinic. When we selected the tests to be involved in our setting, there were a few things that we had considered. For example, social demographic and cultural factors are important when we perform cognitive assessments. We therefore adopted a Hong Kong version of the MoCA test, which had been validated in our local population. The other pictures here show MoCA versions used in other Asia-Pacific regions. Many of the geriatric assessments involve either self-rated or performance-based formats. For example, the assessment of ADL and IADL can be performed using self-rated questionnaires, which are easier to perform, but may be more prone to biases. There are also other more objective measurements that can be done in the clinic. However, these are more time-intensive and requires additional resources. Another example is the assessment of frailty. The assessment of frailty phenotype involves measurement of hand grip strength, gait speed, as well as detailed assessment of physical activity levels. On the other hand, frailty can also be assessed by a simple 5-question frail scale. The choice of the specific tests, of course, depends on our own clinic settings, the goals of these assessments, and the available resources. Lastly, appropriate adoption of digital tools would also aid monitoring and impact patient management, as in the examples shown here. So, ladies and gentlemen, I believe that improving quality of life is the ultimate goal in the delivery of care to the aging population of people living with HIV. We should consider incorporating more holistic assessments, including assessment of functional status and their quality of life in our routine care. Much more has to be done in identifying the optimal model of geriatric assessment and intervention for our older patients, the barriers of implementing the delivery of more holistic care in various settings, and also the outcome measures for evaluation of program effectiveness. So thank you very much for your attention.